Hi everyone, and welcome back to the Learning Stethoscope. Today, we're diving into chronic venous insufficiency, from the normal physiology of venous return to what goes wrong, how it presents, and how we treat it. Want to review this topic in more detail? You can download the complete clinical notes for this video. Check the link in the description below. So, let's start from the very beginning. The heart pumps oxygen-rich blood through the arteries to nourish every part of the body. Once the tissues take what they need, oxygen and nutrients, that blood has to make the journey back to the heart. And that return trip? It happens through the venous system. Now, in the lower limbs, this journey is especially challenging because the blood has to travel upward, all the way against gravity. So how does it manage that? Well, the veins have a pretty clever design. They team up with the surrounding muscles and one-way valves to keep the blood moving in the right direction. The venous system in the legs is organized into three main sections. First, we have the superficial veins, like the great and small saphenous veins. These lie just beneath the skin and outside the muscles. They're the ones we can sometimes see as varicose veins. Next, we have the deep veins, such as the femoral, popliteal, and tibial veins. These run deep within the muscles and are responsible for carrying most of the blood back toward the heart. And finally, we have the perforator veins. These small veins are essential because they connect the superficial system to the deep system. So, under normal conditions, blood flows only in a one-way direction, from the superficial veins, through the perforators, into the deep veins, and finally back to the heart. So, let's zoom in to get a better look. Here we have the superficial vein, sitting just under the skin. Here's the deep vein, running inside the muscle. And connecting the two is the perforator vein, acting like a little bridge between them. Now, under normal conditions, blood flows in one direction only, from the superficial veins, through the perforators, into the deep veins, and then all the way up toward the heart. But how does the blood actually make its way up against gravity? Well, the body has two clever mechanisms to make sure blood reaches the heart. The first one is the valves inside the veins. All three venous systems, superficial, perforator, and deep, have one-way bicuspid valves that only allow blood to move upward. These valves are crucial for keeping blood flowing in the right direction, especially when we're standing upright. They're basically thin folds of endothelium, and their most important feature is that they're unidirectional. So think of them like tiny doors. They open to let blood move up and then close to stop it from slipping back down. This series of one-way valves throughout the leg veins work together to prevent reflux and keep blood moving efficiently against gravity. Now, those valves work hand in hand with the muscles, which leads us to the second key mechanism, the muscle pump. Valves and muscles work together to push blood back up toward the heart, helping it fight against gravity. Remember how the deep veins run within the leg muscles? Well, when those muscles contract, they squeeze the veins and push the blood upward. Now, there are several muscle pumps in the lower limbs, but the most important one for venous return is the calf muscle pump, often called our peripheral heart, because it plays such a crucial role in pumping blood upward. Let's visualize this. Imagine a posterior view of the calf. The deep vein sits between the muscles. When the muscles are relaxed, the veins fill with blood. But as soon as we take a step and the calf muscles contract, they compress those veins, forcing blood upward towards the heart. And that's what happens when we walk. A simple but incredibly efficient cycle. When the muscles relax, the veins refill with blood. And when we take a step, the muscle contracts and blood is pushed upward. So, relaxation refills, contraction pushes up. To give you a sense of how powerful this system is, when someone is just standing still, the muscles are relaxed, so the veins are full of blood, meaning the venous pressure in the foot can be quite high, around 80 to 90 millimeters of mercury. But once they start walking and the calf pump kicks in, blood is pushed upward and the venous pressure can drop to less than 30 millimeters of mercury. However, in a patient with chronic venous insufficiency, this mechanism doesn't work properly, and venous pressure may remain elevated. So far, we've seen how beautifully the venous system works when everything is functioning properly. But what happens in chronic venous insufficiency? Well, the system starts to fail, Instead of blood flowing upward toward the heart, it begins to pool in the legs, causing an increase in venous pressure, what we call venous hypertension. There are three main mechanisms that can lead to venous insufficiency. The first one is valve dysfunction. Normally, veins have one-way valves that prevent blood from flowing backward. But when these valves become damaged or incompetent, blood starts to reflux, meaning it flows in the wrong direction, which increases pressure inside the veins. This valve dysfunction can happen in any of the three venous systems. In the superficial system, incompetent valves allow blood to flow backward, causing the veins to dilate and form varicose veins. In the perforator system, if the perforator valves are incompetent, blood from the deep veins can now flow backward through these connecting veins into the superficial system. This backward flow transmits high pressure, leading to venous hypertension. And finally, in the deep system, this is the most serious type. When valves fail here, blood refluxes through the deep veins and even into the perforator and superficial systems, causing widespread venous hypertension throughout the entire limb. The second mechanism behind venous insufficiency is venous obstruction. In this case, the problem isn't with the valves, it's that the blood's pathway is blocked. This often happens after a deep vein thrombosis, when a clot damages or narrows the vein. Because of that, blood can't flow easily back to the heart, so it starts to build up in the leg, increasing venous pressure. Over time, this constant high pressure causes the valves to become incompetent and veins to dilate. The third mechanism is muscle pump dysfunction. Remember the calf muscle pump we talked about earlier, our peripheral heart? Well, if that system stops working properly, it becomes much harder for blood to move upward against gravity. This can happen in people who are sedentary, have reduced ankle mobility, muscle weakness, or neurological conditions that limit leg movement. Without effective muscle contractions, the veins don't get that extra push they need. So blood starts to pool in the lower legs, increasing venous pressure and swelling. In other words, even if the valves are still working fine, a weak or inactive muscle pump can still lead to chronic venous insufficiency. Now that we understand how chronic venous insufficiency develops, let's look at how it actually shows up clinically. The symptoms of venous insufficiency depend on how long the venous hypertension has been present and how severe it is. To describe and grade these differences, we use a system called the CEAP classification, where each letter stands for a key aspect of the disease. C is for clinical presentation, E for etiology, A for anatomy, so which veins are affected, and P for pathophysiology. We will now focus on the C part, meaning the clinical presentation. So the first stage of this system is C0. At this point, everything looks normal. There are no visible veins, no swelling, and no skin changes. But some patients might already start noticing leg heaviness, fatigue, or aching after standing for long periods, early warning signs that venous pressure is beginning to rise. Now, as venous pressure starts to build a little more, we move into the C1 stage. At this stage, small superficial veins start to appear on the skin's surface. You might notice telangiectasias, also known as spider veins, those fine red or blue thread-like veins less than 1 millimeter in diameter. Or reticular veins, slightly larger bluish veins, about 1 to 3 millimeters wide, often seen around the ankles or behind the knees. So, at this point, the changes are usually cosmetic, and most people don't have significant symptoms. But these tiny veins are actually the first visible sign that venous valves are starting to weaken and that local venous pressure is increasing. Next, we reach the C2 stage, where things start becoming more noticeable. Here, the veins become dilated and tortuous, usually more than 3 millimeters in diameter. These are the classic varicose veins, the rope-like veins that often bulge visibly beneath the skin. At this point, patients often begin to experience symptoms such as a feeling of heaviness, burning, or itching sensations, and sometimes nighttime leg cramps. Symptoms usually worsen after prolonged standing and improve with leg elevation or walking, as movement helps activate the calf muscle pump and promotes venous return. Now, moving on to the C3 stage, this is where swelling, or edema, starts to appear. At this point, the veins can no longer handle the increased pressure, so fluid begins to leak out of the capillaries into the surrounding tissues. Clinically, this shows up as swelling, usually around the ankles and lower legs. The edema tends to worsen throughout the day, especially if someone spends a lot of time standing or sitting still, and it improves overnight or with leg elevation. Over time, though, if venous hypertension continues, this swelling can become more persistent and harder to reverse. By the time patients reach C4, chronic venous hypertension has started to affect the skin and underlying tissues. These are known as trophic changes, and they are divided into two subcategories, C4A and B. In C4A, we can have hyperpigmentation, meaning the skin, usually around the ankles or lower legs, may darken due to iron deposits from red blood cells leaking out of veins. We can also have venous eczema or stasis dermatitis where the skin becomes dry, itchy, flaky, and inflamed. In the subcategory C4B, we can have lipodermatosclerosis when chronic inflammation causes the skin and subcutaneous tissue to thicken and harden, giving the lower leg an inverted champagne bottle appearance. Another sign we can see is atrophy blanche, where we can see white scar-like patches surrounded by darker skin, reflecting severe tissue damage and fibrosis. These skin changes aren't just cosmetic. They increase the risk of venous ulcers, make the skin more fragile, and signal that the disease is progressing toward its most severe stages. Next, we move on to the final and most severe stages, C5 and C6, where patients develop ulcers. In C5, the patient has a healed ulcer. Even though the ulcer has closed, the skin remains fragile, and there's a high risk of recurrence if the underlying venous hypertension isn't treated. In C6, here we see an active open ulcer, usually located around the medial malleolus or inner ankle. These ulcers are often slow to heal and require careful management to prevent complications. So, that's the clinical spectrum of chronic venous insufficiency. From subtle complaints with normal-looking legs in C0, to tiny spider veins, varicose veins, and edema in C2 and 3, skin changes in C4, and finally, the serious ulcer stages in C5 and 6. This classification helps us objectively describe the severity, guide treatment decisions, and monitor progression. Watch the next video, Part 2, where we'll cover the diagnosis and treatment of chronic venous insufficiency. Coming up next on The Learning Stethoscope. Want to review this topic in more detail? You can download the complete clinical notes for this video. Check the link in the description below.